All right. Uncharacteristic as it is for me to start exactly on time. We have a really busy day, packed agenda, and um, and so I'm going to get the obligatory intro remarks out of the way, and then we're going to get right into our program. So it cost us a little bit extra, but we did dial up a sunny day. So hope you all appreciate that. All right. So our educational program is sponsored by our Pediatric Health Network. We are out there really trying to live and breathe and implement the quintuple aim: improving the quality of care, patient satisfaction, managing costs, demonstrating value, improving and elevating the provider and care team experience, and advancing health equity. This is our 25th annual Future Pediatrics. We have it set up so that in addition to seeing the slides on the screen, you can access the QR code on the agenda and actually pull up the slides on your phone or tablet or computer if you want to scroll and follow the slides along the way. And folks can give you a hand, or probably your table mates can sort of point that out. We will have short windows for Q&A. We can't really do those from the table, so we'll invite people to go to the mics, or we'll bring the mics to you. The theme for all of our 25 years, but we're even trying to elevate a bit more, is not simply how do we provide better care in our primary care practice settings, but how do we partner and collaborate with specialists to really help kids get the right care at the right place at the right time across the whole care continuum. And so that theme is going to be built into a lot of today's presentations. We're CME accredited. We have learning objectives that focus along those themes. And you should have your agenda. We have a pretty packed agenda. There are breaks mid-morning and lunchtime and mid-afternoon. So you'll have plenty of opportunity both to learn here, but also to stretch. Because the CME program, all our faculty presenters are obligated to report any conflicts of interest. We've sort of reviewed their presentations, and there are no apparent conflicts. We're just talking about nuts and bolts, who we are, what we do, how to take better care of kids. There are a couple different ways to claim your CME credit. I'm not going to go through all the details from up here. We can help you at the tables. We can help you out at the main registration area, but you can get up to 7 hours of CME credit. We are working through GW. Hopefully by next year, we'll be doing CME back through children's, but we'll see how that goes. Almost all the clinicians are eligible and able to claim CME credit. You should have had this already. We'll provide parking vouchers so you can get out of jail free. The Wi-Fi password, FOP 2024, to help you access the Wi-Fi. Bathrooms are at the end of the halls. If you need help, we have PHN team members all around. Just ask us and we'll do our best to help. The Future of Pediatrics is actually sponsored by our Pediatric Health Network, and there are really no other external sources of funding. We have a meeting planning team of our own staff and community practitioners that sort of come up with the agendas, and we appreciate you all being here and networking with the wonderful pediatrician community. And learning from each other. And with that, I get to bring up our first presenter, who's Dr. Hans Pohl, who is the chief of pediatric urology at Children's National. We're going to stay on a pretty tight timeline here. And just to be clear, following Hans, we'll actually be introducing you to Children's new Chief Executive Officer, Michelle Riley Brown. So you get to meet the new honcho.
A new honcho.
There
Okay.
you go.
What do I do here?
Green advances.
Green advances. Okay. So this photograph is from way too long ago. And the benefit of being a surgeon is that you're in the operating room when all of the headshots are taken. So we are embarking on a brand new model of collaborative care. And what this entails is an approach where we are in stronger partnership with you to bring our expertise directly into the community and hopefully bridge some of the barriers of care. This does require some shared responsibility and expertise in the decision-making process. And the aim is to improve patient outcomes overall. So we decided that we would start with some of the fundamental issues that we see in our office being referred by your offices. And we have begun a work to come up with what are called co-management tools and algorithms which would be available to you in your offices in a variety of formats which suit your personal practice style, whether it would be a tear-off sheet or something electronic that you could access. And while we are creating these tools, the vision is that they will be actually living tools. So we will be able to use your input over the course of the next several years to further refine the tools to address the specific questions that your patients are bringing to you in your office. And so therefore I have, while we have completed some of the documents and 2 more are in the planning stages, ideas are welcome. You will see these tools in your offices, and I would ask that you send any ideas to me directly to my email address at Children's National with the subject line co-management documents, because I'll create a folder through Outlook so that all of your emails will go into a folder that I can get into on a weekly basis and curate your questions. So these are meant to, in hard format, be a 2-page document. So page 1 would be fast facts, things that you would want to educate parents so that they understand what the nature of the problem is in a very general term. Key terms, which goes to the core of how to describe the problem to the parents, as well as what terms to use when referring the patients to us so that we are speaking a common language. An algorithm of assessment, history, physical, the hot button issues that would stratify patients based on a low or high acuity, and then decision points for what would be considered high acuity patients that need immediate referral. So to delve into foreskin problems, for instance, we all know phimosis. Actually, my colleague from Children's Neurosurgery, Dr. John Myseros, is fluent in Greek, and so he would tell you that phimosis comes from phimos, which means to muzzle or to mouth, and osis, which denotes a condition or a state. And so therefore, phimosis literally means a muzzled condition of the penis, which is probably what it should be. There are several types of phimosis, one which is physiologic phimosis. This is the unretractability of the foreskin which is normal in newborns, and it's normal throughout a certain period of life. We typically discuss that between 3 and 5 years of age, most foreskins should be retractable, which is generally true, but not true in everybody. So there is nothing that is true in all of us. We are all individuals, and the idea is to identify where is phimosis a problem that deserves further treatment and where it is not, and where a tincture of time is just as good. Then there's pathological phimosis, which is a response to chronic inflammation of the foreskin which cannot be managed by any other than surgical means, because you now have a fixed scar, and that fixed scar is not going to respond to either gentle retraction or steroid treatment or anything else. Then there's the incomplete circumcision. So boys who have been circumcised but do not meet what we would consider to be the expected appearance of a circumcised penis, which I described to parents coming into my office as basically looking like a rocket ship. So the fast facts that we would provide to you and that you could use for parents is that more than 95% of the children are born with a physiologic phimosis. By the time they are 3 years old, about half of the boys will have a retractable foreskin, the other half will not. By 90%, by 5 years old, 90% should be retractable. But there is a certain percentage of young adolescents in whom the foreskin is not retractable. And the question is it a problem or is it not a problem? We would ask that if the child had a urinary tract infection concern, that we would be provided with urine culture documentation. We would be happy to see patients if there was an inability to retract the foreskin after the age of 5 years old, or if there is any characteristic signs of inflammation of the foreskin or ballooning on urination. We would provide you with management care tips in terms of care of the uncircumcised penis, care of physiologic phimosis, indications for circumcision, and indications for circumcision revision. All of these tips and tools would be to be able to prime the parents so that they understood what we would be discussing when your patients would be coming to us. And the strict criteria for referral, which would be painful voiding, UTIs, 2 episodes of balanitis, paraphimosis, failure of topical steroids, and I'll get into that in a little bit, as well as painful erections. In terms of topical steroids, we have found, along with our European colleagues, that more than 85% of boys with a variety of foreskin maladies can actually be treated with betamethasone, 0.05% or 0.1% ointment applied to the penis twice daily for an 8-week period. It's very important to stress to parents that it must be twice a day, and to stress to them that it does require some time. So there's an investment of nearly 6 to 8 weeks at least before you can decide whether that course of steroids was beneficial. And I would say that in the vast majority of cases, unless parents are really seeking circumcision, most of the parents actually are very pleasantly surprised when we are able to avoid circumcision entirely. In terms of undescended testis, we will discuss key terms such as the undescended or the cryptorchid testis, which is a testis not in the scrotum. So any testis which is not fully descended is an undescended testis and should be referred to us as soon as possible. An ectopic testis is not in the scrotum, but it is also not along the path of normal testicular descent, and so these can be in the thigh or the perineum. And so if you don't find a testis or you don't feel a testis where you expect to find it, you should also search in these other areas. A retractile testis is not in the scrotum all of the time, but it is in the scrotum some of the time. And it can often be manipulated into the hemiscrotum where it remains once traction has been placed on the testis to tire the cord, and you release, and then the testis doesn't bounce up. One of the key things that I teach all of the medical students and residents when they come in is the importance of examining a child in the sitting position. The reason to do that is that the cremasteric reflex, which pulls the testis up, cannot do so when the hip is flexed. So once the baby is about 6 to 8 months old and can reliably sit, I have them sit, and retractile testis will be in the scrotum. And there are many cases of children who are sent to us for undescended testes, where just placing them in the sitting position, taking the diaper off, will demonstrate to the parents very convincingly that both of the testes are there. There are, however, some retractile testes that are kind of a nuisance. And periodically, a patient will come to us being referred for an undescended testis, and the parent will be very convinced, and I truly believe this, that the testis was documented in the scrotum on a number of exams. And the reason for that is that about 10 to 15% of retractile testes may ascend. Now, they don't really move up. My way of thinking about this is that the cord is relatively short. And while the baby is small, the testis is in a normal position. But as the baby grows linearly, this short cord now pulls the testis higher into the canal. And so a testis which is not palpable today may very well have been palpable before. So keep that in mind. 3% of boys will present with an undescended testis. And we really want to get away from diagnostic imaging, which is not accurate. One can certainly obtain a sonogram, and we get a lot of sonograms, but remember, in the supine position, many testes are retractile and they'll be in the inguinal canal. And I have seen many cases of sonograms that have shown the testis to be in an inguinal canal, but when you examine the patient in the sitting position, the testis is indeed a retractile testis. So we do not advocate for any kind of diagnostic imaging anymore. About the only time that I would find it useful is in a patient with a very high BMI. And I will perform a sonogram simply because I'm trying to plan surgery. I know the testis is not in the scrotum. And what I need to do is to tell the operating room whether I'm going to be doing a laparoscopic approach for an intra-abdominal testis or an inguinal approach for a testis located in a very deep fat fold. We do stay concerned about cancer of the testis, whether it was brought down or not. When I was a medical student and a resident, the textbooks would say that there was a 20 to 30 times greater risk of testicular cancer, which never seemed to be concordant with reality because we rarely ever took testicular cancers out in previously undescended testes. More contemporary studies out of Sweden, where they have a nationalized healthcare system, and I guess Sweden must be nice enough that nobody ever wants to move away from Sweden and everybody lives there forever, have documented that at best there's a 3 times greater risk of testicular cancer in that population in previously undescended testes. So it's probably a lot less than what we once thought. We want to definitely bring these testes down by 12 to 14 months of age, corrected for any prematurity. And the reason why is that studies from Children's Hospital of Philadelphia and a group out of Switzerland back in the mid-90s demonstrated that at about 16 months of age, the undescended testis will start losing its fertility potential. It doesn't happen overnight, nor does it even happen over months, but progressively over ensuing years, you start to see loss of the precursor cells that are required to form sperm cells. So the longer that testis remains in an undescended position past 16 months, the greater the likelihood you are going to have infertility from that testis. So if it's not down by 4 to 5 months, corrected for prematurity, please send them to us right away. And we are more than happy to take over at that point. Again, we want to know whether there are any history that might influence the cryptorchid testis, and what's most important is any maternal exposure to progestational agents and any history of differences of sex development. When to refer patients as an emergency is when you see an undescended testis with a hypospadias, because the incidence of genetic abnormalities is much greater, and especially when you see hypospadias in 2 undescended testes, because there's the possibility of congenital adrenal hyperplasia in those infants. And our tools would basically assist you with how to make that decision. This is the way that I think about management of the non-palpable testis. So you can see that, the algorithms can very quickly become quite complicated. Again, these are not provided for you to make any surgical decision-making, but these are going to be provided for you to be able to then show the patients who are in your office what is to come. And we think that having some understanding of how we think about the problems then will facilitate the consultation when patients come to our offices. So I know that my time is limited. I just wanted to make one plug for febrile urinary tract infections. There are a lot of ways to sort of skin this cat, as they say. Typically, back in the 80s and 90s, all patients with a febrile urinary tract infection would get both an ultrasound and a voiding cystourethrogram, historically speaking. And the interest to getting a VCUG on all patients with a single febrile urinary tract infection was to identify all cases of reflux, because it was the big boogeyman of pediatric urology. But those who have been in practice now over the last 20 or 30 years, as I have seen a significant shift in sort of this de-escalation of reflux as an important congenital finding. Their reflux exists in a variety of different contexts. There's reflux that doesn't matter, grade 2 reflux, unilateral grade 2 reflux in an infant male probably is not going to be of great concern, but grade 5 bilateral reflux in a 2-year-old girl with potty training difficulties is probably going to have a considerable impact on her long-term health and well-being. So as we have learned a lot more about reflux in these various contexts, we have started to think of ways to minimize the invasiveness of identifying these more important cases of reflux. So there are a lot of guidelines out there. The AAP has a guideline. The American Urological Association came out with a guideline. Guidelines have come out from Italy, from the United Kingdom, from France, and even from Sweden. And so we are offering to sift through all of this medical data for your patients. All we need is this collaboration. Number one, we need the urinalysis and the urine culture. So when a patient is being referred to us, we need to have this information so that we can then begin to risk stratify the patient. There are a lot of online tools, calculators that we use that input the presentation, the gender, the laterality of reflux, whether there's a DMSA scan that was obtained and abnormal. Basically, there's a myriad of data now that we can actually input to identify which are the patients at greatest risk. We do make a distinction between urinary tract infections that are lower, so urethritis and cystitis and epididymoorchitis, and urinary tract infections that are higher, pyelitis and pyelonephritis, because those are the ones that actually present with fever, and those are the ones that are most likely to be associated with renal cortical injury if they happen repeatedly. UTIs, as you know, are a very common thing, and if you take that 3 to 5% of patients who get urinary tract infections in the first couple of years of life, only 40% of those will have reflux, and only 40% of those will be at risk for renal scarring. So we're talking about, in the context of all of the children that you manage, yes, a very small percentage of children, but we as pediatric urologists would advocate that those very few children who are at a highest risk do need to be identified. And we do now have very good algorithms to hone in on the kids who are at the greatest risk. Sonography, should you get it? Well, you could, but you can expect, and Alejandro Hoberman at Pittsburgh did some really wonderful work, only 10% of sonograms will actually be abnormal. So sonography as an initial tool is probably not the best tool to use, but we still do get it because it's quick, it's cheap, it's non-invasive, and it's easy to find in all sorts of imaging centers, but the yield from sonography is actually quite poor. And up to 20% of those who have febrile urinary tract infection will have the reflux that we care about the most. Just a word about circumcision in boys. So the uncircumcised boy is much less likely to have any significant risk for urinary tract infection. However, if you do see urinary tract infection in a circumcised male, our group has found that they are much more likely to actually have an anatomical abnormality, because you are now having the bacteria being able to get through the sort of the better defense mechanism of the circumcised penis to get into the urinary tract, causing problems. So again, how do we stratify risk? I'm going to, since I have only a couple of minutes left, I have 10 minutes left, but I do want to leave a lot of room because I'm sure that I've got a lot of questions coming. I want to make another pitch for if you have a febrile infant of getting a procalcitonin level. This is something that is completely novel. It does not enter into any of the guidelines, but Gil Rushton and I have done a lot of thinking about this. Some of the more sophisticated guidelines are taking what is called the bottom-up approach, which is reliant on a VCUG, and turning it upside down, saying rather than finding all of the cases of reflux, why do we not instead look for only the kids who are at risk for renal injury? Well, so you don't want to then look at the bladder to identify those. You actually want to look at the kidney. And we've already said that an ultrasound is a poor way of looking for pyelonephritis or any other abnormality. So what else do we have? Well, we have a DMSA scan. DMSA scans are extremely sensitive and extremely specific. We've demonstrated that in our group. They have nearly the same sensitivity and specificity as getting either a CT scan or an MRI. So if we can now identify those children at greatest risk for injury, those are the ones that we want to look for reflux in. Well, of course, part of this algorithm or change in algorithm is predicated on trying to reduce the invasiveness of our algorithms. And as it turns out, procalcitonin is about as good a predictor of a positive DMSA scan as you can get. And it's just a needle stick, no radiation. So one of the things, and this is very new, and I don't know anybody else in the United States which is really doing this, is that what we are moving towards, or we would like to move towards with your help, is obtaining a procalcitonin at the very moment when that febrile infant presents for a urinary tract infection evaluation. So along with a urinalysis and a urine culture, if you can get a procalcitonin within the first 24 hours, if that procalcitonin is elevated, now we know that we have a child at risk for pyelonephritis who may very well have clinically significant reflux. And those are the ones that we're going to expedite through our algorithm and work up appropriately. I think I should probably leave about 5 minutes or so for Q&As. I'm doing okay. I'm going to just skip to what Ed thought was like the niftiest slide, actually, which is my thank you slide. So the reason why this is the niftiest slide is because this QR code links you directly to a virtual business card that I created, which has links to all of the important pediatric urology topics on the Children's National website, and will be another pathway for you to access the tools that we are creating for co-management. I update this regularly, and I also use it for all of our patients. And so now the patients that we're managing in our office and you have the exact same access to information, to our expertise, and we can all start speaking a common language. And hopefully through doing this, we'll actually make our care in Washington, D.C. much more collaborative, much more efficient, and better for your patients. So I'm happy to take some questions in the last 5 minutes that I have. Yes.
Hang on, if there are questions, we're going to bring the mic to you. Just raise your hand. And stand up and introduce yourself. You're among friends.
Hi, I'm Teresa. Thank you. I just had a question about the algorithm for checking the procalcitonin. For the low value, and then you wait for a second febrile UTI, do you check another procalcitonin or just progress on the pathway?
We progress in the pathway. So the AAP guidelines, as I said, what the AP guidelines did was said, look, all reflux is not bad. Okay, so when you're looking at population health, obtaining invasive studies for all patients with a febrile urinary tract infection probably doesn't make sense, because the vast majority of kids are actually not going to get another UTI. They'll get one UTI and, it was a bad luck event, okay? And the NICE guidelines talked about this also, that UTI is such a common thing that, well, we know 5% of children will get a UTI. What we want to do is then isolate the kids who are at risk for recurrent urinary tract infection. So what the algorithm then is doing is essentially waiting for that recurrent infection. Well, now if you have a recurrent infection, whether it's with a fever or not with a fever, you know that there is a risk. So now you're trying to figure out, well, is this child at risk for recurrent febrile urinary tract infections, for recurrent infections in general? And then you start to stratify the patient into those who would benefit from more invasive testing, or those who would benefit from managing bladder and bowel health and all of the other risk factors that are out there. So that's the approach. But if you can get a procalcitonin with the initial febrile event, then it will significantly expedite care. We have seen a stage migration. I'm actually the single individual in our practice of 10 people that looks at all urine culture results coming in for all of the referrals. And I'm seeing more patients who have had multiple urinary tract infections, where there was a period of time 20 years ago where patients were being referred after the first and second UTI. So that was sort of like the old method. And now the new method, and our fear is that the new method will sort of revert back to what pediatric urologists saw in the 1970s and 1980s, where patients would come in after 5 UTIs with significant renal scarring and chronic renal disease. Great. Okay. Thank you. Best of luck.
Online. Good morning, everyone. I hope you enjoyed that. I'm Nathaniel Beers. I'm the Executive Vice President of Community and Population Health at Children's National, and it is my great honor to welcome our CEO, Ms. Michelle Riley-Brown, who will bring us some remarks. So thank you, Michelle.
Thank you, Dr. Beers. Good morning, everyone. As Dr. Beers said, I'm Michelle Riley-Brown, President and CEO of Children's National Hospital, and it is a true privilege to be here with you this morning for the 25th Annual Future of Pediatrics program. I'd like to start by recognizing Dr. Marc Weissman. Marc, where did you go? He's back there. Not only has Marc spearheaded this event for 25 years, but he is also marking 50 years of providing care to the DC community. Thank you, Marc, for your years of service and unwavering dedication. Let's give Marc a round of applause. Thank you, Marc. So this morning, I enjoyed meeting with the Pediatric Health Network Board. We just wrapped up the meeting downstairs. We had a productive conversation on the future of pediatric primary care across our community and how Children's National can support your critical work. My vision for Children's National is to embark on a journey to a truly integrated delivery system that will best serve patients and their families. Key to this vision is what I refer to as customer obsession. An obsession in a good way. Obsession meaning hyper-focus, hyper-vigilant, paying attention to the customer. This is all about improving access to services with the customer as the hub of every decision. It is about deeply understanding families' needs, preferences, and experiences, and using that insight to drive continuous improvement and innovation. And that's what I am committed to as the new president and CEO of Children's National. By prioritizing the patient at the center of every decision, we aim to enhance access to services, create personalized and seamless experiences, and improve outcomes and satisfaction for those we serve. That includes the service we provide to one another. Our primary care partners are customers too. Today's program focuses on primary care co-management and the partnership between regional primary care and Children's National. By working together, we can improve access to deliver the best care for all children across the full continuum of care. Dr. Marc DeFazio, and I don't know if Marc is here. Is Marc here? Dr. Marc DeFazio and Children's National leaders are already making significant strides to help you and your patients access the region's top pediatric specialists. Much remains to be done, and I want you to know that's not lost on me. We have more work to do, but we're making measurable and steady improvements together. We're also working to improve access to primary care across all regions' pediatric practices. Our Pediatric Health Network, which now includes nearly 700 primary care providers in Maryland, Virginia, and DC, is leading efforts to improve care delivery, outcomes, quality-based reimbursement, and collaborative care. Today, our Children's National specialists will highlight how busy primary care pediatricians and pediatric specialists can collaborate to treat common conditions. It's about sharing care across the continuum and improving timely access to specialty care for our most complex kids. I want to thank all of the presenters today and everyone here for your continued partnership with Children's National. We couldn't do what we do without you. I have dedicated the past 24 years to pediatric healthcare, and as the new president and CEO of Children's National, I maintain my steadfast commitment to making the future of pediatrics brighter for all of us. I thank you for being here today, and I hope you have a wonderful session today. Thank you.
Thanks. We're gonna keep moving right along. Hey, you can go home and say, hey, I saw the president today. All right. Not that I would get a big head about this, but our next presenter is Dr. John Myseros, Vice Chief of Neurosurgery, to help provide some perspective and guidance about those boys and girls that we see in our practice, and whom we're often wondering about the size or the shape of their skull and more. Dr. Myseros. The screen button advances the slides.
And
Oh, look
I
at
can
that.
only point it once.
That's okay.
Good morning. Thank you, Mark. Thank you all for attending. When I was standing over there listening, it occurred to me, my younger daughter, she's 27. She has Down syndrome. She's a great kid, pretty healthy, but she always texts me pictures. She's really into pictures, and she texted me a picture of myself last weekend when I was a baby. She got it from my mom. And I was sitting over there. I should have put it, rather than this picture, I should have had that, because my head was massive. I had a really big head, and my head circumference is about 59.5 centimeters, which is, above the 90th percentile. It's big. I won't speak any further about what all that means, but anyway, so I have nothing to disclose. The reason I'm giving this talk is, So you see a kid in your office that has a big head, or you're concerned about a big head, or a full fontanelle, or head circumference changes. And sort of the worst case scenario in most people's minds, whether you're a pediatrician or a nurse practitioner or primary care doc, or frankly, even a neurosurgeon, is, does a kid have a brain tumor? That's about the worst thing they could have, almost. So this is this is a Nellhouse curve, incidentally. This is what I typically use to evaluate kids. It's old for any of you, probably nobody in here is as old as I am, but well, Marc is, if he's been practicing for 50 years. But the Nellhouse curve turns out to be fairly predictive for us. Head growth acceleration on a Nellhouse curve means something. But I would point out this red curve. This is the most common thing that we see from referring doctors. A baby who has a head growth acceleration but otherwise looks okay, and typically if you follow them out, they typically plateau and they're not particularly sick, and they actually don't have any issues. It's the blue line that's more concerning. A child who has fairly rapid head growth acceleration that doesn't plateau, and typically by the time they get up well above the 90th percentile, they're becoming symptomatic. But I'll show you some examples of where that may not be the case. So what we typically see is this: benign macrocephaly, or benign enlargement of subarachnoid spaces of infancy, or benign macrocrania. Essentially, it's a benign condition. Big heads, sometimes they have full fontanelles. Babies otherwise look fine. They typically plateau their head circumference curve, and oftentimes their parents have a large head. It's not always the guy, right? Sometimes it's the mom, and sometimes it's neither, but there's a strong family history. I would add, and I'll reiterate this and say this at the end: when you see babies or children or any patient that you have concerns about or you're unsure about, just send them to us. We're pretty good at seeing patients who may not need surgery, because it's pretty quick for us. It gives the parents some comfort, and we can just reassure you that everything's okay. It's not like you're inundating us. If I can see a child with a flat head or a sacral dimple or a big head fairly quickly and fairly efficiently, and if something sparks our concern, we can work that up as well. So I have in blue here, I typically have a bit of, if you haven't noticed, I have a little bit of attention deficit. I think many of us do, but I definitely do. And it's very hard for me to sit still. And I'm typically, if I'm giving a talk, I have this microphone attached to me and I'm pacing around. And I'm a little jacked up on coffee too. So, and I'm usually pointing at things, but because the screen's right behind me, I can't point. But I have communicating hydrocephalus in blue. The reason I have that is I believe there's a spectrum for these kids who have benign enlargement of the subarachnoid spaces. Kids who have communicating hydrocephalus have imaging studies that look almost identical. So how do you tell the difference? You tell the difference because one set of kids becomes symptomatic and the other doesn't. One set of kids has persistent head growth acceleration and the other doesn't. But I think they fall on the same spectrum of an absorptive deficit. Kids with communicating hydrocephalus, I'll talk to you about in a moment, don't have a block. They don't have a tumor. They don't have aqueductal stenosis. They just can't absorb their CSF. And if they can't absorb their CSF, it backs up and they develop hydrocephalus. These are the kids that we worry about. Kids who actually have pathology, kids who have hydrocephalus or have cysts, or, God forbid, have a brain tumor. And I'm not sure if you were exposed to neurosurgery as medical students, but when I was exposed to neurosurgery as an undergrad, but brain tumors in children, it's all bad. Hang the black crepe, disaster. That's actually not the case at all. There's a lot of kids who have tumors that can have, surgical cures and can do quite well. So hydrocephalus, when we see imaging studies and you see big ventricles, you get an ultrasound and some radiologist sends you a report and says this baby has ventriculomegaly and we're concerned they might have hydrocephalus. Big ventricles and hydrocephalus are two separate things. Most kids who have hydrocephalus do have big ventricles, but not all big ventricles are hydrocephalus. You can have big ventricles because you're a preemie and you have PVL and your brain sort of just shrinks and your ventricles get big to fill in the space. You can have big ventricles from They had meningitis or some other type of ischemic injury. Hydrocephalus is when you're just making more spinal fluid than you're getting rid of, and it creates pressure on the brain, and that will affect development, cognition, and so forth. So this is, I'm not to cause any PTSD, but these are the ventricles. Lateral ventricles, they drain through the frame of Monroe into the third ventricle, which drains through the teeny little cerebral aqueduct into the fourth ventricle, and then it goes down the spine. So there's two basic types of hydrocephalus, the ones that you're born with and the ones that you acquire. So we commonly see, particularly now, babies are being born even at 22 weeks gestation. And really young babies have a high risk for germinal matrix hemorrhages and developing hydrocephalus. We see that at Children's. We have as you know, a pretty prolific NICU, and these babies, because of excellent care, survive. So we have to take care of their hydrocephalus. Post-infectious hydrocephalus isn't too common for us. Neither is post-traumatic, but we do see kids with arachnoid cysts, and unfortunately we see kids with brain tumors who have obstructions and causes hydrocephalus. This is a baby, premature baby born at 23 weeks gestation. Initial ultrasound, these are the ventricles. These little black things. And this is a couple of weeks later. You can see the ventricles get big because there's blood in there. And as the blood resorbs, the ventricles typically continue to get larger and the babies need to be treated. Congenital hydrocephalus, being born with hydrocephalus, we have a pretty big prenatal department, and a lot of babies, most babies nowadays, are diagnosed prenatally. And I would say because of prenatal counseling, some of those babies don't come to term. So we don't see a lot of children anymore with massive hydrocephalus. Some babies don't have prenatal care, or for other reasons, the pregnancies do go to term, and so we have to take care of them. Kids who have spina bifida, open neural tube defects also are way on the decline for similar reasons, prenatal care. Danny Walker malformations, relatively uncommon. So here's a fetal MR. This is a baby inside her mom. She's got hydrocephalus. She has aqueduct stenosis. And this is her CT scan, pretty big ventricles. This is immediately after the shunt. You can see there's a little bit of air in the head. And this is sometime down the road. You can see the ventricles get pretty small. The brain, which has been fairly compressed, re-expands, and the scans look good. How the babies do is a different issue. There's children who have massive hydrocephalus at birth who you'd be hard-pressed to pick up any cognitive or intellectual deficit. There's other children who are absolutely devastated. Communicating hydrocephalus, there is no block. There's just an absorptive problem. This is a baby from Kensington. His parents both work at the NIH, and they came to see me for big head, full fontanelle, head growth acceleration. I was a little bit concerned. We got an ultrasound. It showed some big ventricles, so we did this MRI. So the difference between this and a child who has benign macrocrania is this CSF out here over the convexity, that's a lot. And it's in the back. Kids who have benign enlargement of subarachnoid spaces, benign macrocephaly, just big head like me, usually in the front, not all the way around. And even for young neurosurgeons, they don't know what to do about this. Well, if I put a shunt in this kid, if I put a shunt in the ventricle, what's to keep the brain from collapsing, and those spaces over the convexities are just going to get bigger? Well, they don't. Now, the problem is that they can't absorb their spinal fluid. If you put a shunt in this baby, the spinal fluid outside the brain and inside the brain will go away. So this is a very interesting kid. He's actually 17 now. Both his parents are attorneys, and he's graduated with honors. But he came to see me for a big head from his pediatrician. And I saw him and he looked great, but his head was quite large and his fontanelle was really big and really full, but he was smiling. He's a little bit delayed. Happy baby. And I saw him at Children's, and I set him right down for an ultrasound, and they sent him back upstairs and they said, he's 12 months old. We can't do an ultrasound. I said, well, his fontanelle's pretty big. Do an ultrasound. So they did an ultrasound. It wasn't a great ultrasound, and it's maybe difficult for you all to see. But there's this big black thing over here. This is the brain. Sort of a fuzzy picture, but concerning enough that I got an MR. So he had this really, really big arachnoid cyst. You'd never know it looking at the child. This is the sort of stuff that probably makes you freak out in your office, right? You see a kid with a big head, they look fine, but his head's big. What do I do? Don't worry about it too much. Just really, it's very difficult. I don't mean to be dismissive in saying that. If the child's got a forced downward gaze and puking, and that's a different issue. But if they have a big head and you're concerned and you don't know whether to do an imaging study or just send them to us, really. And it's not because it's the easier thing to do. I think it's probably the most efficient thing to do. So this baby ended up with a shunt. Arachnoid cysts like this one are just trapped CSF spaces. We oftentimes see them. You may have patients who have head injuries and they get an ultrasound or a CT scan and they have an arachnoid cyst. Most of those kids, incidental cysts, they don't grow, they don't have any problems. We see them all the time. Sometimes we follow them, sometimes we don't need to. Arachnoid cysts are very, very common. Big symptomatic ones are not very common. These are various arachnoid cysts. This baby right here, this is the cyst. And this is the brainstem. It's almost pushed to the back of the head. And this baby was diagnosed prenatally, and we really didn't think the family, wanted to have the baby, that she would even breathe when she woke up. But she did, and she was treated. She's, fairly impaired child, but so I wanted, this timing of this patient was good, not good for the baby, but good for this talk. I saw this little guy about a month and a half ago, maybe 2 months ago. Pediatrician was concerned because of a big head. Saw the kid, told the mom, yeah, he looks pretty good. Why don't I see him back and I'll remeasure his head. I'll see him back in a month. I saw him back in a month, head's still growing pretty fast. Fontanelle sort of full, baby looks okay. Mom, trust me. I said, let's do an ultrasound. I'll send you for an ultrasound. So this is the ultrasound. Big ventricles, pretty big ventricles. I looked through it. I couldn't see much pathology other than big ventricles. It looked like the fourth ventricle was small. And she was a little reluctant to sedate the baby for an MR, but I said, this is not normal. The baby's going to probably need a shunt. It's going to need something. The ventricles are way too big for me to just let this go. So we got an MR, and they live out in Reston, but they went all the way to PG, to our MR scanner in PG County, because that was the first one they could get, and the parents were starting to unravel a little bit and get a little bit. So unfortunately, this baby has not just one brain tumor. So he's got this little lesion right here, massive ventricles, right? Those are big. And then it's hard to discern, but there's a tumor right here in the pineal region, blocking the cerebral aqueduct, right? CSF should be coming right through here, and it can't. So when you see when we see babies this young with brain tumors, they're typically malignant tumors. So I did an endoscopic procedure. I just put a scope in there, and I biopsied the smaller tumor, that guy, and I did a third ventriculostomy. I poked a little hole right here to allow the CSF to get out without placing a shunt. It turned out to be an ATRT. If anybody's familiar with teratoid tumors, they're really malignant tumors. He's being treated now. But my point in bringing up this child is this is the kid that you guys really worry about. This is the kid that I worry about. To be honest, I've been doing this for a long time. I may not be the smartest guy on the planet, but I have a lot of experience. I trust my judgment implicitly. And I got completely blindsided by this. I did not see this coming at all. I could have just as well said, you know what, why don't you come back in 2 more months and let me measure the head? And then maybe if we're concerned, we'll do an MRI. It turns out that for this kind of tumor, it probably didn't matter so much. He's, may have gotten a little bigger by the time we did that, but he's still, probably not going to do well from this kind of tumor. This is a newborn. Look at the size of that tumor. That was a teratoma. This is a tiny little choroid plexus carcinoma with massive ventricles. This is this kid's x-ray, really big head. Both of these kids, by the way, are, you know, in their teens now, and I'll say they're thriving, but they're doing well. So this leads us into the sort of the second half of this talk. How much time do I have? I'm okay. And for those of you that know me, you know that I take care of a fair number of children with brain tumors. And at Children's, we have a fairly vibrant pediatric brain tumor program, and in my opinion, the best in the country. All due respect to Boston and St. Jude. We have really cutting edge stuff. So we see a lot of kids with brain tumors, and I think we take very good care of them. Brain tumors are more common than you might think. So your anxiety about seeing a baby that has a big head, or some kid who's got some symptoms of increased intracranial pressure and maybe having a brain tumor, are well founded. A lot of these tumors are benign, so it's not all bad, but they are common. They're the most common solid tumor we see in kids. And about the 5,000 number comes from a database that we're a part of. I think that number is probably closer to about 3,000. What they include as brain tumors are, you know, metastases and kids with leukemia who end up with intracranial disease as well. We see all sorts of different kinds of tumors. The most common tumor in adults are gliomas, astrocytomas. Unfortunately, in adults, you know, a lot of, particularly adults, you know, past the age of 40 have glioblastomas, fairly malignant tumors, like, you know, Ted Kennedy and a lot of other people have succumbed to these tumors. And unfortunately, babies can have, or children can have glioblastomas as well. It's not as common. Kids have another really bad tumor, this one, a diffuse pontine glioma, which I will talk about towards the end, because there's a reason I'd like to spend a little bit of time on it. But we see children with all sorts of different kinds of tumors, and even malignant tumors like medulloblastoma. Medulloblastoma is, by definition, a malignant tumor. And 60 years ago was 100% fatal. But with the advent of radiation therapy, the outcomes started to improve. And any of you that have been practicing long enough who have children who've been radiated as young children know the deleterious effects of that. I can see a kid who's been radiated as a baby from 10 miles away. They have a very specific appearance, and they're cognitively quite impaired despite what surgery they may have had. But Roger Packer, who's the head of our brain tumor program, 30 years ago started working on this, and now, depending on the subtype of medulloblastoma, there's kids who have an 85% cure rate. There's other kids who have group 3 and group 4 medulloblastomas. That doesn't mean much to you guys, but they're on the more malignant of the malignant side, and those children don't do nearly as well. So I don't want to bore you with surgery. I mean, it's what I don't find it boring. That's what I do. And even at 60, I turned 60 in January. Regarding heads, it's always, I see a few shiny heads in here like mine. My boss, when I was training, said, God made some heads perfect. He put hair on the rest. So, unfortunately, because of back to sleep, and back to sleep is not unfortunate. It's good. It's all good. But there's a lot of kids with flat heads, and that's a completely different discussion. You can talk hours about flat heads and craniosynostosis and such. But because of plagiocephaly, not all heads without hair are going to be perfect anymore. You can start seeing older kids who were born in the early 90s who maybe have short hair or losing their hair, and they have asymmetric heads. So we look out for symptoms of tumors, particularly in older kids. Babies like the one I just described may not have very many symptoms. So I don't know if you all remember the tentorium. It's this shelf here that separates the top of the head from the bottom of the head. The hemispheres and the ventricles are up here. The brainstem and the cerebellum and the fourth ventricle are back here. So this is a huge space. This is a pretty tiny space. This will accommodate a huge tumor. This will not accommodate a huge tumor. There's the suprasellar space. The pituitary gland is right here. There's the optic nerves. and the pineal region where your pineal gland is. And if you remember Descartes said, this is where your soul is. And operating in this area, which can be quite treacherous, it's one of the most difficult things I do. You see why you would think maybe your soul is there. It's a hard place to go and it's a hard place to operate. So symptoms of these tumors depend on where they are and how big they are. And I won't go through every single problem, but supratentorial tumors can present really, really big, particularly if they're growing very slowly. Sometimes a child may have almost no symptoms, maybe a little hydrocephalus, or maybe a little bit of a headache. And despite a massive tumor pushing on their motor cortex, we have a child who was admitted yesterday who has a pretty big brain tumor right in the motor cortex, in the primary motor cortex. And aside from a headache, the child has no symptoms, presented with a seizure. Talk about seizures in a moment as well. Does anybody know what a Gerstmann syndrome is? You do? Oh, Marc DiSabella, my neurology colleague, is the only one that raised his hand. They're probably the only nerdier person in the room than me. Marc. So a Gerstmann syndrome is a dominant parietal lobe syndrome. You don't see it very often, but it's kids who can't differentiate between right and left. And they also have other very specific things. They have they have difficulty with very simple arithmetic. 2 + 2. They have finger agnosia. They don't know which finger is which. If you tell them to put your left thumb on your right ear, they can't figure out what their thumb is and they don't know where their right ear. But if you speak to them, they sound perfectly fine. Posterior fossa tumors, I mentioned the ones in the back. You know, those, because of their location, kids can have cerebellar findings, ataxia, they can have brainstem findings, 6 nerve palsy, facial nerve palsy, various cranial neuropathies. Pineal region tumors, where our soul is, obstructive hydrocephalus because of the cerebral aqueduct. You remember, it's quite small. It doesn't take much to compress it. And a paranode syndrome. So these kids have an up gaze problem. Not a forced down gaze like we learn for hydrocephalus in a baby, where their eyes are sort of pointing down and they can't look up. These kids have almost normal gaze until you ask them to look up. And they don't understand it and they don't pick it up because most people who have this problem just lift their head. It's quite subtle. But if you have them not lift their head and try to look up, they can't get their eye past horizontal. And supracellular tumors that grow around the pituitary gland, kids can have endocrinopathies, diabetes insipidus. If they're big enough, they can have visual pathway issues, a bitemporal hemianopia, you know, tunnel vision. Diencephalic syndrome is rare these days, but big optic pathway tumors can present, these kids present with big heads from hydrocephalus and these scrawny little cachectic bodies because their diencephalon has been just crushed. So what are the aims of surgery? Well, I mean, ultimately we want to help the kid or the baby, right? I mean, you see a baby who's sick, you want to make them better. But you also need to make a diagnosis. You also want to cure them if you can. If it's a benign tumor and you completely resect it and you can do it safely, you may cure the baby or the child or the teenager. If they have obstructive hydrocephalus from the tumor and you take it out, maybe they don't need a shunt or they don't need any more surgery. But we really try to do everything we do without hurting the child. The little kid I showed you who has the ATRT, who had those 2 little tumors, and I did an endoscopic biopsy. So if I didn't have to, I didn't want to subject a child to a shunt. We put shunts in lots of kids, right? I'm sure all of you have shunted children with hydrocephalus. And if you do, you understand that shunts carry a risk over your lifetime, not an insignificant one. Malfunction, infection, perforating a gut, all sorts of stuff. So if you can avoid a shunt, that's a good thing, and which is sometimes we can do endoscopic procedures and do that. So this is a baby who was not diagnosed prenatally because they didn't have prenatal care and was not descending during the mom went into labor and they delivered the baby by cesarean section. And you can tell this is the scout image from this CT scan. That kid's got a really, really, really big head, this baby. And what you can't tell is the eye is proptotic. It's sort of sticking out. And then a little further down on the scan, essentially the entire intracranial space is a tumor. And these are the sutures, like the coronal sutures right here. It's really quite splayed. So there's nothing we can do for a baby like this. There's nothing to be done for a baby like this. There is no brain. It's a massive, invariably malignant tumor. Let the baby stay with mom and dad until, they go to heaven. We don't see this very often, but this is on the worst side of worst. Pituitary tumors, I mentioned, we don't see often in kids. We do see craniopharyngiomas, which I'll go to next. But in the adult population and now in the pediatric population, you can take out these tumors through the nose. One of my young partners, Dan Donahoe, trained doing endonasal endoscopic surgery. So we don't go underneath a lip with a microscope anymore, just go through the nose with one with a scope and one with your instruments, and with an ENT surgeon, you can take these out. The view is actually quite good. Again, we don't see pituitary tumors often in children, but for the ones that we do, this is a really nice technology to do it with. Here's a craniopharyngioma, much, much bigger tumor. Goes all the way back here. I have a fair amount of experience taking these out subfrontally, underneath the frontal lobe, underneath the brain. These are pre and post-op images. Here's a supratentorial, fairly straightforward tumor, an ependymoma. We just go right down to the tumor to take it out. This is a medulloblastoma we do from the back. The one caveat here is we don't just, it's hard to just explain this to parents. You don't just open up and say, oh, there's a tumor and you take it out. That's not how it works at all. You have to sometimes locate the tumor. You want to get in there as minimally invasive as you can. You don't want to hurt the child. For this tumor right here, this medulloblastoma, this is the brainstem. This tumor is sitting on the brainstem. Typically, they lift off the brainstem. But you go charging in there, in the old days, they put their finger around the tumor and just pull it out. And I think probably in some places in the world where they may not have that technology, they still do that. Well, that's asking for trouble. And sometimes they got away with that and sometimes they didn't. So it's not, I know sometimes we're considered, surgeons, and we have to wear clogs so our knuckles don't drag on the ground. But the truth of the matter is that at least in neurosurgery, we tend to be thoughtful and careful, and we're fairly cutting edge. At Children's, I'd say we are on the cutting edge, and we use various ways to take care of children efficiently and most importantly, safely. This is the sort of stuff that makes me worry it. And I don't worry about a lot at night, but this is one of the surgeries it does. This is a big pineal tumor, and the arrow shows how we approach these. It's a very narrow corridor. At the bottom of where we're looking at the tumor is probably about a centimeter to take out this 4 centimeter tumor. So it can get difficult, but the kids do remarkably well. We do have a lot of improvements that help us. I mean, ultimately experience and skill is probably the most important thing, but we have intraoperative imaging. We have an MRI in the operating room. We have a CT scan in the operating room. We have an ultrasound in the operating room. Functional imaging, I'll show you in a moment. Our oncologists have the latest, greatest chemotherapy, biologic therapies. Nowadays, they do molecular testing. They can offer unique, tailored treatment to kids for their specific tumor, depending on what the molecular biology is. And I mentioned the endonasal approaches to go through the nose. This is a medulloblastoma. This is a before and after ultrasound. I know it may look fuzzy to you guys, but here's the tumor. And you have to take my word for it that ultrasound looks pretty clean. It's very helpful for me in particular. I don't like to use the MRI too often because it takes quite a bit of time, and you have to put the child in the MRI scanner during the surgery, and the ultrasound is very quick, and we're pretty facile at it. This is a functional MRI. So the Bill Guyard, who's the head of our neurology department and head of epileptology, runs our functional MRI program. If we have a kid like this one who has a tumor, this teeny little tumor, very near where I thought might be the motor cortex, the primary motor cortex, and they got a functional MRI. Here's the tumor. It's just, I'll take down the green dot, but right where my green dot is that tumor. And where that blue is where the motor cortex is. They have kids tap their fingers and count and do various things. So I know that if I want to take out this tumor, I'd be much more likely to not hurt the child's motor function by going behind it rather than in front of it. Here's diffusion tensor imaging. These are fascinating images. These are the motor fibers from the motor cortex going right through the internal capsule, and the tumor is out here. So I know that coming interhemispheric, probably not a good idea. Coming from the side, lot less likely. Here, you can see here. Here's the motor fibers, and here's the tumor. So you can avoid deficits with some of this functional imaging. I mentioned the endoscopic procedure. So this is a craniopharyngioma I did from here. Right, we sort of remove a little piece of bone here and take off the roof of the orbit and go underneath the frontal lobe. And this is after the tumor's out. This is the carotid, the right optic nerve, the optic chiasm. That's the basilar artery in the brainstem. If that looks scary to you, it's scary to us as well. It's scary to me as well. But you know, you just got to put your boots on and take care of it and do it carefully. But this is also craniopharyngioma done through the nose, and the tumor's out. So this is the basilar artery. This is the brainstem. So the nose is right here. So it's a remarkable view. It's a lot more narrow, but the surgery that can be done now through the nose for these cellular lesions is pretty remarkable without opening up the head or touching the brain or anything like that. I did mention that not all pediatric brain tumors are awful. We see a lot of children with these. This blue line here are pilocytic ascytomas. You can see the outcomes are quite good. Germ cell tumors as well. The majority of germ cell tumors are germinomas, which are, Hans isn't here anymore. But the majority of germinomas are essentially histologically like seminomas. They're malignant tumors, but highly responsive to chemo and radiation therapy. You know, over 98% of kids with germinomas will be cured. But they don't all have, I have a child right now who has a mixed germ cell tumor who will require radiation and chemotherapy until it shrinks, and then we'll have to remove the rest. And I mentioned ATRTs and high-grade gliomas. I want to take a moment just to discuss this one specific tumor. This is the glioblastoma of the adult population for me. Anybody ever had a kid with this? Yeah, this is essentially a fatal disease. For those of you that have any of the Netter books or looked at the Netter atlases when you were in medical school or even now, this is a poor image of it, but this is from Frank Netter. This is a kid with a pontine glioma. Hemiparesis, facial nerve palsy, 6 nerve palsy. And for whatever reason, we see a lot of them are sent to us. When a child was imaged and they had this tumor in their pons, they would get radiation, they would eventually succumb to their tumor. John Shillito, who was one of the old chairmen at Boston Children's, said, if you've diagnosed this tumor and the child is still alive 18 months later, you made the wrong diagnosis. So they're really bad tumors. We didn't even biopsy them because the risks of biopsying the brainstem are quite high. It turns out that we can now do it. I have a very large series of brainstem biopsies for pontine gliomas. And the information is actually used. Somebody might say, well, what are you going to, if these kids are going to do well, what does it matter? It does matter because with molecular testing, you might even pick up a tumor that's not a pontine glioma, maybe a PNET or some other type of tumor. But there are other therapies now. Now, this is all on protocol, but I want to talk just very briefly about focused ultrasound because our institution has, I'll give a shout out to Hassan Syed, one of my younger partners, and Bob Keating, who's our chief. Hassan has the world's largest experience of giving low intensity focused ultrasound to pontine gliomas as part of a trial to see if these kids do well. We have a very big Dr. Packer, Lindsay Kilburn and Adriana Fonseca, 2 of our oncologists, it's one big team that are leading this charge to try to help these kids. Essentially, it's ultrasound, but it's a lot of ultrasound rays that are focused into one spot to try to ablate certain areas, and in some cases to open the blood-brain barrier to allow for drugs to get into tumors. Low intensity focused ultrasound is used for these kids, DIPGs. So these children get a biopsy, they get radiation therapy, and if the family is open to it, they'll do LIFU, low intensity focused ultrasound. They have multiple sessions trying to improve the outcomes. The data's not out, so I can't tell you if it works or if it doesn't, but we'll be the first to tell you. We'll be the first in the world to tell you. High intensity focused ultrasound is a one-time shot, small tumor, surgically inaccessible, needle biopsy, prove it's benign, and ablate it. So all that's great. I've dazzled you with stuff that may not be all that applicable to your practices, except for the macrocephaly. What you guys really want to know is, who do you send to us? Say everybody. And who should you scan? And when should you scan? And what kind of scan should you get? You know, I would say up to 10 years ago, the easiest thing to do, baby, open fontanelle, still nowadays, easy, quick ultrasound. Ultrasound resolution is fantastic now. If you couldn't get an ultrasound, you'd immediately get a CT scan. Well, nowadays, most institutions, certainly ours, the Innova system, we'll do a limited MR. It's a 4 or 5 minute image. Baby doesn't need to be sedated. Young kid doesn't need to be sedated. And you can see if there's grossly anything wrong. Are the ventricles big or is just some massive tumor? The best picture, of course, is a formal MRI. So I would point out that, you know, a new onset seizure in an adult is a brain tumor until proven otherwise. A new onset seizure in a child is seldom a brain tumor. The kid who was admitted 2 days ago, actually had a new onset seizure. He's a little older, but it's not that common for tumor presentation. Worsening headaches, morning vomiting. We still see children who've had upper GIs, CTs of the abdomen, all sorts of, because they continue to have morning vomiting when indeed what they really have is a posterior fossa tumor. New onset problems, visual loss, sixth nerve palsy, numbness, unilateral symptoms. And in the very young, full fontanelles, symptoms of increased pressure. So I'm part of this team here. So this is Bob Keating. He's our chief. Dan Donahoe is our youngest guy. He's got this interest in endonasal surgery and has research interests in AI and how it might contribute to neurosurgical care. This is Chimal Libo. He has probably the most extensive pediatric epilepsy practice in the country and will use HIFU, high intensity focused ultrasound, to treat dystonia in children. He's treated the first patient, I think, in the country. And this is Hassan, who I mentioned, Hassan Syed, who does all the LIFU stuff and has particular interest in vascular neurosurgery, and this knucklehead over here. So I don't know if there's enough time for questions, but I'm happy to entertain any questions you may have. Hi, Catherine.
Hi, good to see you, John.
You as well.
Dr. Myseros took care of my son with I'm Catherine Cross, primary care pediatrician in Northern Virginia. And Dr. Myseros saw my son at 9 months who has a really big noggin and measured my head, which is farther off the curve. But my question was about some of the ancillary treatments that are now available. A friend of mine in her 40s has a stage 4 glioblastoma multiforme and post-surgery radiation, and I don't know what the rest of her protocol is using something called an Optune device that uses electrical fields. Is there any role for similar, I guess it's a helmet she wears 23 hours a day?
It is. It is a helmet with magnetic fields that are focused on the tumor. We have not used it.
Not in pediatrics?
No, we haven't at children's.
Oh.
I have seen a kid from CHKD in Norfolk who was older. She was 16. So I think there is an age cutoff for that. And I don't, unfortunately, I don't know the outcomes, but I don't know how your friend is doing, but I think short term, there's been some benefit. Not to making the tumor smaller, but to keeping it from getting bigger.
I think my understanding is that's the goal.
Yeah. Thank you, Catherine. Anyone else? Okay, well, thank you so much for coming and listening to me. I appreciate it.
Dr. Myseros puts all these images up there and, well, heads, and I start to get a headache. um, and thankfully, he did remind us that while this drives a lot of concern, not just for pediatricians, but for families or those sorts of things, thankfully, true brain tumors in kids are rare, and he sort of pointed out the things to watch for. What is very common in pediatric practices are headaches. And we see lots and lots and lots of kids who have headaches. And some of it is worry that the families may have that there's something more serious going on, although headaches in and of themselves can be quite the problem. And to help put that in perspective and develop strategies for managing these in your office, and collaborating with our specialists, we're thrilled to introduce Dr. Marc DiSabella, one of our pediatric neurologists, who will be joined a bit by Dr. Holly Kim, one of our primary care pediatricians. So Marc, bring it on. Put it into perspective for us. To advance is just this green button. No. Shadon, I think we're on a different slide deck. We need to bring up the headache presentations. Yeah, we only have like 400 slides. You know, it's like, here we go. We're getting close. Great. We're in business.
Is it, so like, will I be able to see?
Yeah, I think so. Let's see.
Yeah, there.
Still waiting for it to display.
Yeah.
Getting closer. Just hang with us for a sec. No, we're going to try to make this, we're going to try to get this right. We're getting closer.
Very close. Hey.
All right.
Great.
Thank you all for your patience.
Great.
Thank you.
Hi, thanks everybody. Thanks for your patience while we're getting those ready. So I'm Marc DiSabella. I'm one of the neurologists at Children's National for over 15 years. I'm the director of the headache program. And so today we're going to talk about headache co-management. And so really, again, in the spirit of the entire session here at Future of Pediatrics, headache is kind of an ideal one for us to manage together as a team. And so I'm going to walk through kind of what that looks like on the ground. So I do run several clinical trials at Children's National. These are all drugs that are FDA approved in adults that we're now doing trials in kids. None of these will have any effects on my slides today, and we won't be talking about them specifically. So today, what I want to do is really talk about defining the characteristics of the primary headache disorders, migraine, tension, and the trigeminal autonomic cephalalgias, which are the cluster headache ones. We're going to talk about the indications for neuroimaging. And despite just seeing so many brain tumors, the good news is these are very infrequent in pediatric headaches presenting just as an isolated headache. We'll talk about the indications for imaging, and then we'll talk about how we can co-manage this together as a team so these kids can stay in your office for a lot of the basic migraine care because that's appropriate. And really, you will be empowered, I think, by what we're creating as part of the PHN to really get you the tools you need to manage this in the office and be successful with most of those kids. So I think it's always important to just start off with, why does this matter to me? And it's because migraine is the biggest pediatric headache disorder that we really see in real life. So if we added up all the diabetes and asthma, we are still smaller than the headaches and migraine that are in the population. And this is true of pediatrics as well. Just before I came up, I pulled the ADHD numbers as well. And ADHD affects about 10% of the population. So migraine affects about 30 million kids. And we're talking about 6 million in ADHD. So I think everybody in this room is managing lots of depression, lots of asthma. You're helping with the diabetic patients in terms of some co-management. And so migraine is really ripe fruit here, I think, for a co-management phenomenon. And so this is really critical to all of our patients and their care. And again, this is not just in adults. So in kids, migraine affects about 25% of females between 15 and 25. So 1 out of 4 female patients you're seeing will be affected by migraine in that age range. Interestingly, males are affected at a younger age. So you'll see a larger percentage of prepubertal males. And then during puberty, most males' migraines will get turned off. And this is when female migraines get turned on. And that has to do with the effects of epigenetics and hormones and a variety of factors that leads to that. But again, we're seeing a really large population of this. If you then break that down into patients with migraine who has more frequent headaches or chronic migraine, that's about 1% of adolescents. And then new daily persistent headache is a headache that's there every day, all the time for at least 3 months. We have a very large population of that in DC. And in fact, there were presentations at American Headache Society and Child Neurology Society years ago over the kind of endemic or epidemic we have in the Washington, DC area. But new daily persistent headache is a disorder of type A perfectionist, high functioning families. We have a ton of them in the DC region. And you'll see a lot of these kids that present with this constant daily headache disorder. And it really fits that patient population well also. So you're now, you have your chief complaint, you're going into the exam room and the patient says, I have a headache. And so you got to get your good history. And so I think one of the key parts of this in my mind is getting the history from the child before you ask the parents any questions. So I actually have this very obsessive tactic of seating. And so everybody that knows me in my clinic, I organize chairs a very specific way. And I make sure the patient sits next to me and can't make eye contact with their parents. It's not to be cruel. And I see heads nodding, you know what I'm doing, right? So I don't want them to get approval from their parents for their answers. I actually want their unbiased answers. One is I want their history. Kids are also really good at answering questions that are like binary or like 4 answers, like what part of your head, and they don't tend to go into long stories about that, as opposed to parents sometimes elaborate a little bit more. So from an efficiency standpoint, you will be more efficient if you ask the patient than the child, in my experience. So set your room up the right way and ask the right person. It's the kid. I do this from 3 years of age on. I have a little difficulty with kids under that, but honestly, I still try. So anybody that presents with headache, talk to them first, set up the room the right way so you can talk to the right person and then get the questions asked. And then in terms of the questions you're asking, I think these are pretty apparent, but what I see often is people jump into the aura questions really quickly, and don't worry about the aura. Establish your primary diagnosis first. So where is it on your head? Front, top, sides, and back. We don't need anything more specific than that. I describe the pain scale in different ways based on my mood probably and the patients for the day. But I always say the scale, the rule of the pain scale is that you can never say a pain smaller than a 1 or bigger than a 10. And remember, there are crazy things in the world like cheetah attacks. So this is a very common line in my office, but I'm trying to define that like headaches should not be 10s because you have to have somewhere to go with this. And kids tend to respond to that really well. And again, these numbers aren't going to drive a ton in your management. So you can kind kind of make it a little bit of a joke in there too. Quality is your next question. So what does it feel like? Most kids need some examples. So throbbing, pounding, pressing, squeezing, stabbing, these types of words. And really, you're just trying to hear, is it sinusoidal or is it flat? Migraine tends to be more sinusoidal. That's like throbbing, pounding, pulsating types of words, as opposed to tension headaches are kind of flat. They're more of like the squeezing, pressing, tensing type of headaches. After that, you want to know, what do you do when you get a headache? Do you rest or do you move around more? That's the two options there. Kids will usually say, I stop playing, right? I sit down, I lay down, whatever it is. In terms of light and sound sensitivity, don't ask them if they're light and sound sensitive, because they'll usually say no because they're afraid of the dark or they don't mind it. And noise, they want to hear music, so they won't say they're sound sensitive. So ask a question more like, do you mind really bright areas? Do you mind the lights at school that are fluorescent? Do you mind going out in the sun when you have a headache? Or do you mind a noisy cafeteria? Does your sibling yelling make your headache worse? Those questions you'll get the bite on, as opposed to like, are you sound sensitive? They'll just say no. And then in terms of nausea and vomiting, you ask those. You'll hear a lot of yeses with nausea. You won't hear a ton of yeses with vomiting. But I think those are the right questions. Once you ask those 8, you've now established which primary headache disorder they are, which we'll go into next. And now you can move forward. Again, you can then get into auras and red flag symptoms, which we'll talk about. They're really not going to change your management. So don't get too hung up on them. Really focus in on these 8 characteristics of headache. Okay. So these are the 3 major primary headache disorders. So you have migraine, tension type headaches, and the TACs. TACs is where cluster headache falls. There's actually 7 disorders in there of varying duration. Don't worry too much about them. We've seen over 20,000 patients with headache in the last 10 years, and we've had less than 10 with a TAC. All right, so these are unlikely. When you hear cluster, people are usually just describing a headache that's around the eye, or it clusters in the number of days in a row. That is not what a cluster headache is. A cluster headache is a headache with autonomic features that are seen on the face by other people. So they have ptosis, or a dilated pupil, or a red eye, or a drippy nose, or a sweaty forehead. They're really rare. So don't get too hung up on those. Think more about the migraine world, because at least in my clinic, 95% of patients that I see will leave with a diagnosis of migraine, chronic migraine, intractable migraine, but it'll be in the world of migraine. So we've already talked about the symptoms we're going to ask about. So a migraine is simply defined as a headache that has 2 major, 1 minor criteria. So they're typically frontal or unilateral, throbbing, pounding, or pulsating moderate to severe headaches, make you want to lay down, dark and quiet, nausea, vomiting. Keep in mind, you only need 3 of those. So a patient with migraine might have a day where they have a frontal 10 out of 10 throbbing headache that makes them lay down in the dark and quiet. They may also have a day where they have a occipital 1 out of 10 headache that is still throbbing and makes them want to lay down in the dark. That is still a migraine, because they had 2 major and 1 minor criteria. So treat the wimpy headaches that fulfill the criteria for migraine as migraine. Because if they're more aggressive treating the milder headaches, they might not need to get the bad ones. The bad ones are probably little ones that are kind of piling on themselves. So I go through this a lot with families, because again, you can empower them to use their migraine treatment plan, even with the milder headaches. They don't need to wait for the bad ones. They can treat the mild ones as long as they fulfill criteria. Tension type headaches are kind of the opposite of everything with migraines. So these are more diffuse. Some people say they're band-like, but these are going to be mild to moderate. They're not throbbing. You don't need to lay down when you get them. People are still light and sound sensitive, because who wants to be in the bright and noisy room when you have a headache? And there is no nausea and vomiting. Okay, so differentiate between those 2. The symptom in red on here, the activity symptom, that's the only symptom that is specific for all 3 disorders. So migraineurs want to lay down, tension type headache patients do whatever, and TACers, the trigeminal autonomics, they become restless and agitated. So if you can only ask 1 question of a patient with headache, it's what do you do when you get the headache? I published a study when I was a fellow on this. It was really sensitive. We gave school nurses a little card. They asked 2 questions. If they asked that one, they got the right answer pretty much every time. Okay. So we wanted to talk a little bit about this in FOP, just because it's important that these patients leave with the right diagnosis, because this actually affects your practice. So we're trying our best to code as specifically as we can, and that's going to affect actually the amount of reimbursement you're getting from insurance companies. When we code intractable disorders or chronic disorders, that affects the payments that come back to your office and practice. So it's really critical that we're as specific as possible for this. So I put different terminology up here, which includes episodic, which is people that have headaches less than or equal to 8 days a month. Acute, which means it's less than 3 months. Chronic, which means it's more than 3 months and more than 15 days a month. And then intractable is kind of soft. So the technical definition of this is you failed 3 medications, though, 3 preventatives. But I have to admit that this is not a hard definition. This is not included in like ICHD or ICD-10 coding. There's no actual term. I'm sorry, there is a term, but there's no definition of it that's strict. So if you see somebody, honestly, that's failed 2 medications, I typically code that as intractable because that's considered intractable in epilepsy and other disorders. And so then try and think through your case when you're seeing the kid that presents with, I have headaches every other day that fulfill the criteria for migraine. And then on top of that, I have headaches on the other days that are really mild. That's probably going to be a patient with chronic migraine. And then if they didn't have aura, without aura. So try and put all those words in each time. That'll bump your ICD-10 codes out to 3 digits past the decimal. And that's the ideal number you're trying to get in there. If you can get 3 digits out, all of a sudden you're going to start seeing your reimbursements go up for your practice, which is really important to what you do for a living too, to keep your doors open and get all the staff that you need. So who needs imaging? So is Dr. Myseros still here? Perfect. All right, good. So almost no one. All right. So I'm so sorry that you saw that a lot of them do. And the good news is we have found 5 brain tumors in the last 20,000 kids. All right. So it is very unlikely. So there's some reasons for this. Okay. So first off is a tumor, the only pain sensitive structures in your head are the meninges and the blood vessels. So your tumor, unless it pushes against those, doesn't cause pain. So headache is unlikely to be the only symptom. So about 60% of tumors in kids are in the posterior fossa. They're in the cerebellum or the brainstem. So they're going to present with ataxia, or if it's in the brainstem, they're going to have brainstem findings, usually double vision or some sort of wonky eye movements. If it's in the cortex, it's going to cause a seizure most likely, or weakness on one side. So again, the likelihood that they present with isolated headache is very low. And even better than that is the exam is key. So this is a meta-analysis on about 600 kids, and they basically looked at all these kids that had imaging and had headaches and who actually had a brain tumor, and only 14 of the kids had a tumor, and 100% of them had abnormal examinations. And those 5 tumors I told you about, 100% of those had abnormal exams. So the key is the exam. The problem with that is the exam can take time to do a good neuro exam, and it includes the fundus, which everybody does not enjoy looking at unless you do it every day, all the time. So my suggestion here is keep practicing and trying on every kid. I have a whole separate lecture on how to do a neurologic exam for pediatricians that I give, and it talks about how to do a fundoscopic exam. I don't want to go into the details today, but it's not as hard as we've made it out to be. And really, you just need to see the circle kind of flash by for a second. And if the edge of it looks pretty sharp, that is probably not papilledema. And that's all I'm seeing in real life too. So happy to come back anytime or talk to your individual practices about that. But that's what you're looking for. Otherwise, you're looking for weakness and hyperreflexia, asymmetries, like a pupil that's asymmetric or eyes that aren't moving out all the way. All right. So when this study kind of was analyzed, so really patients with recurrent headaches that have abnormal neurologic exams should always have an image. And that image is an MRI as long as we can get one. And then in terms of if I can't see the fundus or I can't do a good neuro exam, what are the actual historical points that are relevant or statistically significant? And that was an absent family history of headache. Notice it doesn't say migraine. That just says no first degree relative has had a headache. This is unbelievably unlikely. All right. And I've never found a tumor for that one. Number 2 is a headache with substantial confusion or emesis. This isn't, I can't do my math homework. This is, I don't know who mom is, or I don't know where my bedroom is. This is encephalopathy. This is a really serious change in mental status because they're obstructing, right? They're actually having hydrocephalus intermittently. Or substantial emesis, which is more than 4 episodes of vomiting for multiple hours in a row. So it's not a kid with a headache that throws up. It's a kid that is throwing up a lot. headaches that repeatedly wake a child out of sleep. So I think we have to be careful about this, but it's not kids that have headaches that go to bed with a headache do wake up with their headaches. This is kids that the headaches wake them up. So they didn't have a headache 4 a.m. every night of the week. A headache pops them up out of bed. I saw that kid one time in my career. They had a tumor. John operated on it and they did great. But that's the story you're looking for there. And then finally, if there's a family history of brain tumor or a family history of multiple cerebral brain aneurysms. So unfortunately, 4% of the population has an aneurysm. That is a big number and it's scary, and I'm sorry to say it. But multiple aneurysms is hereditary. That's now in that polycystic kidney disease gene. And so when you hear about an individual first-degree relative that has had 2 aneurysms, that's the group you're looking for, okay? All right, so you've gotten your history, you figured out their primary headache disorder. Now we're going to treat them. So in terms of the treatment, we're trying to reduce disability. We're trying to improve their quality of life, give them some pain coping strategies, and reduce disease progression. And so to do that, we need a standard headache treatment plan. So part of our project with the Pediatric Health Network is to get our headache history, which we already use, into everybody's EMRs, and also get our treatment plan into everybody's EMRs so you can start using this in practice. So it focuses on lifestyle modification, behavioral management, and rescue plans, because if you do these 3 things, 75% of your patients with headache will have half as many headaches that are half as bad. 3 out of 4 kids will have half as many headaches that are half as bad, and you will impart 0 risk to these patients. All right, this is really clean stuff. There's also something called the PEDS Migraine Action Plan. This is already built into Cerner. We will try and get this out everywhere also, but this is available free online. And this is the asthma action plan for headaches for school. And also the whole back of it is headache accommodations. You don't need to write unique ones for your patient. You just give them this sheet. And these are the headache accommodations for everyone. Okay, they always work. They're the right ones. They're the same ones I give everybody. So they can get to school despite their headache, have their action plan there. And this will really save a lot of time. It's a quick dot phrase or whatever your EMR is, it'll be built in. And so this can really help out. So what do you actually offer them? So great study that came out in 2017, 19, it'll be up here soon, but CHAMP it was called. Basically, that was that 75% number I just gave you. So what you have to do to get there is you instruct everybody on 4 lifestyle habits plus 1 vitamin. So hydration, exercise, sleep, and diet are the 4 goals. The specifics of it are listed here. It's roughly your weight in pounds equal to ounces, cap it at about 100. So in other words, 60-pound kid, 60 ounces, 80-pound kid, 80 ounces, 120-pound kid, 100 ounces. You don't want to go over 100 ounces. I've seen a few kids get hyponatremic because they're excessive water intake. So just be careful about that when you get over 100. Avoid all caffeine and artificial sweeteners. So these bind to the autonomic nervous system. They bind to blood vessels. Blood vessels are where migraine comes from. So we want to avoid those in the diet. We want kids to exercise aerobically. This is not walking to school. This is not walking the dog. So they have to breathe heavy. And if they trigger their symptoms, that's good. We want to push threshold for pain higher. So just like in concussion, we say exercise until you feel the symptom and push into it for a minute or 2. We don't want to shy away from that. We want to get it higher. Okay, so that's what the aerobics look like. Sleep, a big key to this is not sleep shifting on weekends. Kids that get jet lag on Friday and Saturday because they sleep shift get headaches on Tuesday and Wednesday. It's usually 2 to 3 days of a delay after that. Scheduled naps, deregulate REM sleep. REM sleep comes from the same part of the brain that migraine comes from, the hypothalamus. So we don't want people napping in the day. This is bad for headache disorders. And finally, eating something or drinking something with calories within an hour of waking up. I tell them all the time, I don't care if it's healthy, your brain only uses glucose. A Jolly Rancher is sufficient for breakfast. I don't care. Just break the fasting state because cortisol is the problem. So cortisol is released when you're fasting. When you eat about 50 to 100 calories, it goes away. Blood vessels get to tighten back up. Migraine is a disorder of loose blood vessels. This is an easy way to do that. Behavioral strategies, we want kids to participate in activities despite headaches, distract themselves as best as they can. That desensitizes their brain, that pushes their pain threshold higher. And we tell families, don't ask or talk about pain. Don't keep calendars. Don't check in with your kid about this. So calendars, unfortunately, increase frequency because the more people are keeping track of things, the more they're checking in with themselves about it. You're scanning your body. How's the headache now? Do I have the headache? What's it feel like? Those are the questions that are coming surrounding that. There was a good study that came out showing that if people didn't keep a calendar or the parents kept a secret one, it turns out that the kid's estimate was as accurate as the calendar. So I don't need an objective number. I actually just want to see an improvement in their perceived quality of life, their disability. So a kid that actually goes from 10 to 15 headache days a month, but is going to school every day and going to after school practice, that is the goal. So I'm fine with that. And I don't need them to actually have a reduced number in total number of headache days. So for the sake of time, I'm going to go a little bit quicker on a few slides because I got to give Holly some time as well. So NSAIDs are our first line, ibuprofen 10 per kilo. Whenever you give a rescue, advise them on maximum use, which for NSAID should be 3 days in a week because more than 15 days in a month will get you medication overuse headache. We give sports drinks, you'll see from the headache program all the time. This is because highly processed carbohydrates have been studied over 70 times, and they reduce pain by about 2 points on average. They're so highly processed, they can cross the blood-brain barrier without a transporter, so they make your brain happy, so they take the edge off stuff. So G2, Gatorade Zero don't work. You need high fructose corn syrup, so a Sprite and a bag of chips works too. In terms of rescue meds, so if you're going to go to the next step in co-management here, which we really think you should be enabled to do, these are the triptan medications. If you just want to always pick the same one, it's Maxalt. All right, rizatriptan is Maxalt. Don't pick Imitrex anymore. There's no evidence Imitrex works. In fact, there's 4 studies that it failed, but Maxalt is FDA approved down to 6 years old. You give 5 milligrams if they're under 40 kilos, 10 milligrams if they're over 40 kilos. They can take it 10 times in a month. Super safe drug, good evidence for its effectiveness. Comes in a melting tablet and a regular tablet. So just pick Maxalt, and you don't need prior auths, and most insurances will cover it. So all of the things we need, right? And then I'm going to breeze past CHAMP here. It'll be in the slides, but this is the study that talked about those lifestyle techniques. Interestingly, if you did the hydration, exercise, sleep, and diet, but didn't take a pill, it didn't work. So this is why we give everybody CoQ10. You'll see it all the time, CoQ10 and riboflavin. So I prefer CoQ10. There's better data on it, and it comes in more palatable forms. Riboflavin stinks like a fart, whereas CoQ10 comes in gummies and capsules and pills. So CoQ10, 100 milligrams twice a day for 4 months, makes it all work. And that's how you'll get that 75% number with the 4 lifestyle plus CoQ. Preventative medications. So I have these listed in terms of what we use, the dosing and the titration pattern. If you want to start one of these, amitriptyline is my go-to at any age. I use this down to kids as young as 3. The goal dose is 1 milligram per body weight kilogram, and you titrate that by 10 or 12.5 milligram increments, but that's all in the slides that we'll share, and hopefully you all have access to as well. For the sake of time, I'm going to go past this one, but basically the modifiable risk factors for headache include obesity, caffeine and tobacco and alcohol use, lack of exercise, and poor sleep. So things that you would already be counseling on are really imperative to their headache wellness. And this is just walks you through the 8 steps that we just talked through. So again, headache's very common in the population. We want to get the right diagnosis, try and code it right if you can. Talk to the kid about the symptoms before you talk to the parent. Talk to everybody about the lifestyle habits like hydration, exercise, sleep, diet, give them the preventative vitamin, and then give them a rescue plan. If you're going to use a triptan, give them Maxalt. It's the easiest one. I don't get any money for Maxalt. I don't even know who makes it. And then preventatives start with CoQ. And Holly, you are up. Sorry to eat in your time.
Thank you. I am going to talk about headache co-management from the PCP perspective. So some of you may know there's a PHN headache co-management group, which consists of several PCPs from various PHN practices, Dr. Fox and the PHN group, Dr. DiSabella, and some of the neurology team members. And we meet periodically. We're going to finish in the fall. So we have goals that have not been completed, but I'm going to share our plan with you. So the first goal is to streamline and improve care of patients with headaches. And we would do this through readily available headache guidelines right at the PCP visit. We would be easily providing up-to-date treatment options and patient resources. and to know when and how to refer to the Children's National Headache Clinic. And the best way to achieve this would be to have this information straight in our EHRs, and I'll get to that in my next slide. But the second goal also is to improve communication with our specialists, in particular to have efficient communication. For example, how do we refer urgently to the headache team? We've all had situations where we don't want to send them to the ED, but we want them seen in the next week. So here is a HPI template in Cerner, which is what CNPA uses. They're called auto text. And as you can see, it has all the headache questions Dr. DiSabella mentioned, red flag symptoms for when we might want to send them to the ED, and MRI recommendations for when the parents want a MRI, but we know they don't really need one. We will have these recommendations straight from our specialists. And here is a plan template. And as you can see, it has all the lifestyle recommendations. It also has the well-studied medications listed. So for example, when you prescribe coenzyme Q10, and we know that there's a strong placebo effect, and since these recommendations were made with the specialist, hopefully the patient will have more confidence and better effect from these. And we will also include the migraine action plan and other resources from the headache clinic. And hopefully once this is all done, we will provide it for all the PHN practices. And we will also include when to refer to our pediatric neurologists. And again, this is done with the specialist, so there's better communication. That would include intractable headaches for when we try our preventatives and they are not responding. Or if the patients are interested in clinical trials or in treatment modalities that we don't feel comfortable with. Or if there's complexity or time constraints, if the parents are reluctant to medication use and it takes a long time, or the patient has comorbid conditions like anxiety and depression, making the treatment complex. So I did want to highlight that there is an urgent headache team with 6 attendings and 50 to 100 urgent access appointments weekly in various locations, so that we would be able to refer patients to this clinic. And you can also see that the headache team is comprehensive, including the behavioral pain team, physical therapy, neurosurgery, research assistants, and they're all available to us. So finally, as we finish this headache co-management project, we will get you lots of information and definitely more to come. Thank you.
We have about 3 minutes for questions, and then we have a break. So our presenters will be available, but if folks have questions, go to the mic, just introduce yourself. You're among friends.
Hi, I'm Virginia Grace Cohen. I'm with Pediatric Care Center in Bethesda. I have noticed with some private pediatric neurologists that they order EEGs for kids with headaches. Is there any utility in that?
No,
Thank you.
correct. Thank you for noticing.
Hi, Joe Sue, THH Pediatrics. Any role for melatonin or cyproheptadine for migraine, and then oxygen for cluster headaches?
So, yeah, sorry. The question was any use for melatonin, cyproheptadine for migraine and oxygen for cluster. So melatonin, yes. So there's evidence in pediatrics and adults on this. The dose is 3 milligrams or less 3 hours before bedtime. One of the common things I see is too much, too late at night. And so I cycle it. I do 3 milligrams 3 hours before bedtime for 3 weeks and take a week off. I find I get more efficacy out of it that way. That's just been my trend, and I do that for concussion too. Cyproheptadine has no evidence for its effectiveness. It was an old 1950s kind of practice that reviewed their studies. I've not seen it be effective, to be quite honest, and I find the weight gain to be excessive with it. I do use it in some cyclic vomiters. And then if you see a cluster, yes, oxygen can be used to abort it during the actual cluster event. That being said, I have to say I have much more success with triptans, work really well for cluster, and I can't get oxygen for people for cluster at their houses. Is the problem. So I use it in the ER. Yeah. Yeah, insurance won't bite. They need to have a vent or something. Yeah.
So we'll have time for these two questions
Sure.
and then break. So
Hey, Brooke Boker, Nova Children's Adolescent Medicine. Can you just speak to any growing data to support the use of birth control pills with people who have migraine with aura, particularly not the hemiplegic kind?
Yeah. So it's we've talked about this before. So the question is about oral contraceptives and migraine. So oral contraceptives that contain estrogen increase the risk of headache. If you look at all of the various ones, whether it's low or not, there's about a 20 to 40% incidence of headache in patients that take them, independent of if they ever had headaches in the first place. So more often than not, you will cause headaches with OCPs rather than prevent them. They are not indicated in the treatment of menstrual associated migraine called catamenial. So we don't use them to regulate periods because that makes headaches better. And then there is a practice guideline from the CDC and the American College of OBGYN saying if patients have aura, they should not take estrogen containing oral contraceptives because they will increase the risk of their stroke by 2 to 4-fold. This data is not causative, however, it's correlative, and I question this pretty deeply. And so I have a very genuine conversation with families about the risk of stroke if you become pregnant is much more elevated than the risk of somebody with migraine with aura taking OCPs. And so you have to weigh your risk benefit ratios there and just talk about risk and have a conversation with families about what they really want out of that. So it's a great question.
Hi, I'm Yvonne Bing. I'm General Pediatrics. I'm with Pediatric Urgent Care currently. What is the role of Zofran with, because I do find that to be very helpful.
Right. Yeah. So Zofran is an anti-nausea that binds to serotonin receptors. So I actually use it less frequently than the others. The reason is triptans also bind serotonin receptors. So I don't want to get serotonin syndrome. So Zofran plus any of those triptans can increase the risk. Reglan and Compazine have very good evidence for their efficacy in migraine, independent of their anti-nausea properties. Compazine has 86% efficacy in migraine abortion. That's the highest efficacy of any rescue drug ever released to the market. So patients that see our group quite often will leave with Compazine as their anti-nausea. Oral doses are unlikely to cause dystonic reactions or tardive dyskinesia. That tends to be high doses, IV pushed fast. So I don't worry about that too much. Reglan tends to be a little bit dirtier and a little less efficacious. So it's usually going to be Compazine or prochlorperazine. Great. Thank you.
great. Doctors DiSabella and Kim are around, and we'll actually have a little bit of a collaborative care Q&A later in the morning. We're heading into a break. It's a long morning. We'll reconvene probably around 10:50. There are bathrooms at the end of the hallway. There's an exhibition hall immediately behind us. The coffee service has been moved there. There's actually water bottles in a refrigerator in the corner for those of you who are interested. And we're thrilled that you're all here. Get a break, stretch, check your text messages and emails, and we'll reconvene around 10:50. Thanks.